In this video, we're going to talk about the J point. Often people will struggle to find the J point, which leads to struggles in diagnosing ST elevation or recognizing ST elevation on a 12 lead. So what we're going to talk about here is how specifically the J point occurs. So what does it mean from a physiological standpoint? And following that, what we're going to do is look at some tips and tricks on how to find the J point. So to better appreciate how to find a J point, we have to recognize a couple of things. One is that our QRS complex is indicative of ventricular depolarization. So when you are looking for a QRS complex on an ECG, what you're really looking for is evidence that the ventricles have depolarized. So we're looking at ventricular depolarization. And what we have to appreciate is that when we're looking at ventricular depolarization, which we can draw onto our heart here, is we're looking at the positive flow of current down and around the ventricles in order to create depolarization. So as tissue is depolarizing, that is recognized by the positive flow of electricity or a change in our membrane potential to be more positive in these tissues. We know that for ventricular depolarization, what's causing that typically is the flow of sodium into cells. So sodium is the primary ion that's causing depolarization, and what we're seeing is a net positive flow of charge as sodium makes its way into cells during the process of depolarization. When we're looking at the QRS complex, all we're looking at is whether that flow of ions is moving towards the camera or away from the camera. So as that flow moves away from the camera or the lead, we get a negative deflection, and as that flow goes towards the camera, we get a positive deflection. So again, here we can almost represent that by we see flow of ions moving down. If we had a lead here, we have the flow of ions moving down towards the lead, and then up and away from a lead. Well, that's going to lead to a change of positive to negative deflection. So the QRS complex is recognized by both positive and negative deflections from baseline, and that occurs because we see positive current, which is caused by sodium influx into cells or a change of positivity into the resting membrane potential, towards the lead that we're looking at. When we talk about the ST segment, what we're looking at is the segment of time where the ventricle is basically at rest. So what we're seeing here is a period of time that is characterized by neither ventricular depolarization or ventricular repolarization. Essentially, nothing is happening in terms of net movement of charge. So we see no net movement of charge in this case. So there's no net movement of charge following by our T wave, which is going to be represented by ventricular repolarization. So our T wave is going to tell us that the ventricle is repolarizing. And ventricular repolarization, which I've drawn in yellow here, is the opposite of ventricular depolarization. So what we're seeing in ventricular repolarization is the net flow of negative charge, or what we're seeing here is potassium efflux from the cells. The resting membrane potential is becoming more negative. And as that occurs, that is typically moving away from the lead that we're looking at. So again, if we use, this is the example of our lead. So our lead is positioned down here and is watching the flow of electricity. What's happening with our T wave is that we're seeing the net negative flow of charge away from the lead. So we see ventricular repolarization, which is characterized again by the net negative charge as we're having potassium exiting the cell and the resting membrane potential is becoming more negative. So we see repolarization, which as a net negative charge flows away from our camera, we see a positive deflection. So this is again a net negative. And that negative flow is the result of repolarization or a resting membrane potential that is becoming more negative. So again, the T wave here is ventricular repolarization. So the important thing to recognize is that the J point and the ST segment are going to be really related to the end of ventricular depolarization and the start of ventricular repolarization. So when we look at our ECG, our J point is right here. So the J point, it marks the start of that rest period before we have ventricular repolarization. So when we look at the J point is that point in time that marks the end of ventricular depolarization. And what that means is that we see the period of rest before we have ventricular repolarization. And what's important is that during this time, we have no net movement of charge. Essentially, nothing is happening from a charge perspective. So when we're trying to locate the J point, one of the strategies that we can have is we should look at the end of ventricular depolarization. And we know that our net movement of positive charge is going to move towards and away from our lead. So we should see some negative and positive deflections. Know that after our J point should be a period of rest, or we should see that period of rest following the J point. So essentially, I'm looking for the period of time in which the QRS complex is going to stop negatively or positively deflecting from baseline, and I see a period of rest followed by ventricular repolarization, which is our T wave. Now, the ST segment can vary in size depending on how quickly we move from ventricular depolarization to ventricular repolarization. So something to be mindful of is that sometimes we don't get the same distance in between ventricular depolarization and repolarization that we see in our initial example. So here the J point is right here, and we're just noticing a much shorter ST segment here. So again, the J point can be identified because we're seeing positive and negative deflections from baseline. We have a period of rest before we have our T wave, so our J point must be right here. So that is the technique, or that's how we should be looking for our J point, or that should help us find our J point. What we'll do is I'll show a few examples of J points here that we can use to get an idea of where the J point is. So if we take a look at these examples, again, what we're looking for is a period of time in which we see the QRS complex is no longer having positive or negative deflections from baseline. And following that, we're looking for that period of rest before we see the onset of the T segment. So what I'm going to do here is in pink, we're going to kind of just look at the positive negative deflection. So here we can see that the QRS complex is positively and negatively deflecting from our baseline. So we can see those happening here. We have a period of rest, which we can identify, and then we have our T wave. So if we use our red marker here, we're looking for that change. So we're looking for the change between where we stopped having positive and negative deflection of our QRS complex. So that would be around here. We're watching that change stop. We know that our period of rest is here. So that point of time in between is going to be the J point. So the J point is right here. So again, we can see this small negative deflection occurring right here, followed by this period of time where we have rest. So that indicates our J point being here. We can do the same on the next image. So on the second image here, again, we're looking for positive and negative deflections from baseline. So there's a positive deflection. Here's a negative deflection. And now we can see where that is ending. So we're no longer seeing positive and negative deflections. We now see a period of rest, followed by our T wave. So in this example, we would know that our J point is right here. So it's basically the change in time for where am I having that negative deflection stop, or that positive deflection stop, and the rest period starts. So again, we can do the same in our next example. So we're looking at positive and negative deflections from baseline. So we're seeing that here. Where do they end? It's ending around here. And where does the period of rest start? So we have a rest period that's starting in here, followed by a T wave. So if this is the case, then our J point would be at that change in deflection from where do I start the rest period after the QRS complex stops positively or negatively deflecting from baseline. A few more examples on this one. We have a really wide QRS complex, so we're seeing a big wide QRS complex. We see our deflections are still occurring all the way up to the top here. So where does that end? Followed by a very short rest period in this case. So here we can see that we have a very short rest period, but if that's the case, then we know our J point is going to be in between those two things that are happening. So we can still locate our J point despite having a small rest period here. In our next example, the opposite is true. So we've got our positive negative deflections of the QRS. In this case, we end at the positive deflection, and we have a very long period of rest in here, what appears to be a long period of rest before we have a negatively deflecting T wave. So in this case, the J point is going to be in here. So we see, again, the cessation of the positive or negative deflection of the QRS complex, followed by a period of rest, and then the T wave. Again, in our final example, we can do the same thing. So we're looking at positive and negative deflection from baseline, followed by a period of rest, which we can outline here, which would then mean that our J point is going to be here. So again, some strategies for you in terms of locating the J point. Again, the relevance of the J point is that the J point is going to indicate where our ST segment starts. So the ST segment is going to live in between the J point and the start of the T wave. So this is our ST segment here. So ST segment is going to be again, this period of rest that we've indicated in pink, and that's how we're going to determine ST elevation from baseline when we're taking a look at a patient's ECG. Something to be mindful of is when we are looking at ST elevation or depression from baseline, we're going to compare the ST segment or that period of rest that we see here to the baseline following the T wave, and more preferentially, we're going to be looking at the PR interval of the following complex. So if we had, say, a PR interval here like this, we would be looking at comparing basically the ST segment located in pink here from this PR interval. So we'd be drawing our straight line from there and making our determination of the ST segment as we're looking at the distance between the ST segment and that line we've drawn from the PR interval that occurs after the ST segment that we are looking at. So that's how we typically be looking for ST elevation. What we'll do now is we'll take a look at a heart that is having infarction. So someone who's having a transmural infarction, I can link here to why we see changes in our ECG in transmural infarction, but we'll use this time to basically look at, again, finding the J point in ST elevation MI and why or how that's occurring here as it compares to the J point. So we know that during infarction, what is happening is we have transmural ischemia to our cells. And that transmural ischemia is going to result in the release of metabolites from that tissue. So we start to see the release of things like potassium from that tissue, which will flow away from the transmurally damaged area. So we have the net positive flow of ions away from that transmural tissue. So what's important to recognize about transmural infarction is that because I'm releasing this potassium and it's flowing away from my lead as a result of my lead positioning and where the damage is, what's going to happen is I have almost constant net positive flow of charge away from my electrode or my lead. And this is important because it's going to lead to baseline changes for my ECG. So if I draw in my normal ECG here, like we talked about before, my QRS complex, my J point, my ST segment, and my T wave, what becomes altered when I'm having a myocardial infarction is that I have this constant, and that's what's important here, nearly constant net positive flow charge away from my electrode. And what that's going to mean is, we talked about before, when I have positive charge that flows away from my electrode, it leads to a negative depression or negative consequence on my ECG. So when I'm looking at the baseline, it typically is going to lead to a negative looking baseline. So as we have constant net positive flow of charge away from my camera or from my lead, what's going to happen is the baseline goes down. Again, usually this would be a rest period. I would see nothing happening during this time, but because of this net positive flow away from the electrode, what's going to happen is the baseline goes down. So instead of seeing nothing, we're actually watching that potassium flow away. So that potassium is flowing away from the electrode, which is making our baseline move further down. Now, in terms of what our QRS complex and P waves look like, they'll look the same because we're having the same consequence. So when I'm having an infarction, I'm still having the net positive flow of charge towards the camera when I have depolarization. So I should still see my QRS complex looking as it does. And what's challenging here, why I get ST elevation, is because once I've had depolarization, nothing is happening. All of the sodium has moved into the cell. We know that we're waiting for potassium to leave the cell. And because of that, all we see is the fact that depolarization has happened. So depolarization leads to a state where we've had all ion movement that can potentially happen. And this, during an infarction, is the only time that the ventricle will appear to be totally at rest. So because we've had ion movement during ventricular depolarization, we're not yet having repolarization. And because we've had very widespread aggressive depolarization of tissues, I will not see that flow of potassium during that time. So because the entirety of the heart has entered a state of depolarization, or essentially this big positive charge, I no longer see a net flow. So because the resting membrane potential has gone up on all my cells, everything looks so positive, it's impossible to see this net flow of potassium. And that's why in an infarction, our baseline appears as though it goes back to normal. So our baseline is going to come right back up here to what appears to be normal, characterized by essentially a period of time evidenced by no net movement of charge. And again, we're seeing no net movement of charge because everything has become so positive with ventricular depolarization that I can no longer see this potassium moving away. So very different than my baseline period of time where nothing is happening. I've had no depolarization, so it's easy to see this potassium flowing away. Once I've had widespread depolarization, everything is so positive that it masks this flow of positive charge from the damaged tissue. So I don't see that. Following this, we will have ventricular repolarization, which will lead to our T wave. And the T wave in ischemia can appear a number of different ways. I have a video on T wave changes in ischemia that you can watch, and I'll link here. So when we're looking at ST elevation on a 12 lead and we're trying to find elevation on a 12 lead that would indicate infarction, I'm looking for that change in baseline, but it's still going to be characterized by that J point. So at the end of the day, the core thing here, the core thing I'm looking for is, when do I stop having positive and negative deflection from my QRS complex, and where does that period of rest start, which is going to be right here. So when I'm looking for ST elevation on my 12 lead, I'm still just trying to find that J point. So I'll be looking again at my QRS complexes for where do I see the QRS complex no longer positively or negatively deflecting from baseline. Where does that period of rest start, followed by the T wave? And as a result, the process looks the same of identifying the J point, which in this case is right. So what we can do is a little bit of practice in terms of what the J point is indicator, how we can see the J point. So what we can do here is a little bit of practice on how we can find the J point in someone having an ST elevation MI. So what we're going to do is take a look at a few examples of ST elevation from baseline where the J point lives. So remember, when we're looking at someone who's having a myocardial infarction, or we're looking at ST elevation related myocardial infarction, the reason we get that ST elevation is because our true baseline, or what we're looking at for the most part when we're talking about baseline, is actually well depressed below where it normally would be. This is the result of the flow of positive ions or potassium away from our lead at rest. So it's essentially a constant negative or constant net positive flow of charge away from our camera. So we're seeing that here, and we can see that in these cases, or these examples. So when we look at our baseline, we're seeing what appears to be a fairly normal baseline, followed by our QRS complexes, which we know we're looking for are positive and negative deflections from baseline to indicate a QRS complex. And where it can be confusing here is that we have no clear rest period. So we go from our QRS complex directly into our T wave. And some of you may be asking, well, how do I know that that is the T wave? So how do I know that this is T wave rather than the S wave? And one of the good ways that we can tell is that we watch this complex. So it's a positive deflection from baseline. It looks like a T wave, followed by, again, that rest period or the baseline that we would typically see, and a P wave. So it's this section here that tells us that that is the T wave, because we see a clear baseline followed by P wave and another QRS complex. So that is highly indicative of the T wave. So if we go back and go, well, where is the J point then? We know the J point occurs after our QRS complex negatively or positively, or is negatively into positively deflecting from baseline at the onset of a rest period followed by the T wave. If we don't have the rest period, then we're simply looking at the junction between what is the end of the S wave and the start of the T wave, which the T wave is going to be dotted in red here. So that ST segment lives where that J point lives, and that's what we'll be using in order to determine ST elevation from baseline. When we're drawing our ST elevation or trying to figure out where it exists, what we want to do is basically draw a line through the ST segment, and you want to also draw a line through the PR interval that's going to occur after. So our PR interval is here, so we draw a line through the PR interval that occurs after, and the amount of distance between those two sections is going to be our elevation from baseline, or our ST elevation from baseline. So we can do the exact same thing on a few other examples here. So using V4R or V4 here, what we can see is, again, a QRS complex that has a negative deflection, a small negative deflection, followed by a positive deflection, and here a period of time where we have a negative deflection and it's going to head into our T wave. Again, what we're looking for here, because we have a very short rest period, that rest period would basically be at the bottom of this little valley here before we start to see the T segment come in. So our J point is right about here, where we start to see the change in deflection from that QRS complex. So again, when we're looking at trying to determine ST elevation, we draw a line through that J point. We're going to use the PR segment that follows the rhythm to be the guiding point here for this. And as a result, we're going to take the distance between those to find out our ST elevation. If we do this again on the next rhythm that we look at here, we can see negative deflection from baseline, positive deflection from baseline on our QRS. And here, again, we have to be careful in recognizing the T. So this is our T wave. And you can see a very small little dip here where we're kind of moving up. So J point is here, where we can see we're moving in the positive kind of concave direction, followed by a slight change to convex here, and that is where the J point is. So we're looking again, that change in deflection. If we map our lines out again, we can measure the distance, and that's what's going to tell us where our elevation is or how much elevation we have. On this final one, again, we can see we're looking at a QRS complex that has a few deflections from baseline here prior to entering the T wave. We can see a more defined segment of rest here before we enter our T wave, and that is again going to be where we kind of have our J point. So the point in between the positive negative deflection for the QRS, so the changes in deflection for the QRS and that rest period is our J point. So we can draw our line through that J point, and then we're going to look at the PR interval. So in here, we can draw our line from that preceding PR interval, and that's how we're going to determine our ST elevation from baseline for these patients.